Hello, everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's my pleasure to be with you for this fabulous session. Our session is titled Improving Healthcare Value Through Analytics. The organizer and moderator is Angela Taylor from the Kentucky Cabinet for Health and Family Services. And this session is sponsored by Milliman MedInsight. Milliman MedInsight is an enterprise data management and analytic reporting organization. They deliver contextualized insights combining data intelligence from inside and outside your organization with powerful analytics derived from over 70 years of industry-leading expertise. They work with 8 APCDs and multi-payer health plans across the country with a commitment to ensuring that our clients have the highest quality data and most advanced analytic groupers and methodologies with which to make data-driven decisions with confidence. So I'm going to bring on stage with me now our organizer and moderator, Angela. It's good to see you, Angela.
Hi.
And I'm going to turn the time over to you to introduce our first presentation.
Okay, thank you. Ladies, gentlemen, and gentle them, welcome to our breakout session. I know that we're reaching the end of the day and the end of the conference, and I hope that you've had a great experience so far, and I hope to continue that with this session. Today, we have 3 insightful presentations that will address the transformative power of analytics in enhancing healthcare outcomes. Please welcome our esteemed presenters, beginning with Krishna Vasareddy. Krishna is an accomplished healthcare research analyst with a passion for interpreting complex data and creating insightful visualizations. With a background in pharmacy and health informatics, Krishna has spent the last 3 years at Delaware Health Information Network, where he has played a critical role in analyzing healthcare data and providing meaningful interpretations to inform key decision-making processes. Krishna?
Good afternoon to all the participants and presenters of the NADO's 30th Annual Conference. My name is Krishna Vasareddy, and I'm joined by my esteemed colleague, Dr. Gurpreet Kaur. Today, we are excited to present our research on the Delaware brain injuries study and in-depth analysis of the impact of brain injuries in the state of Delaware. Traumatic brain injuries have been labeled as silent epidemic by the Centers for Disease Control and Prevention. TBIs result in an annual expenditure of $76 billion. Beyond the financial burden, TBIs have significant long-term implications for individuals and their quality of life. These injuries can lead to a range of physical, cognitive, and emotional impairments, affecting daily functioning, relationships, and overall quality of life. Additionally, TBIs can have a profound impact on society, including increased healthcare utilization, rehabilitation services, and lost productivity. So, with this in mind, we wanted to zoom in and understand the prevalence of TBI injuries in Delaware. Our primary objectives are to identify the prevalence rates of traumatic brain injuries in Delaware, stratified by age group, gender, year, insurance type, and severity. We also want to understand the characteristics of the TBI persons with regards to follow-up care. What percentage of this population is receiving the follow-up care, and how many are receiving the follow-up care within 30 days, and how far are they traveling to receive these follow-up services. With this information, our goal is to empower the State Council for Persons with Disabilities to champion improvements in Delaware's approach to traumatic brain injuries, so that we ensure better prevention measures and enhance support for affected individuals. Our study timeframe included data from 2013 to 2020. We identified TBI population using the ICD-10 diagnosis codes related to brain injuries. We classified the severity of these injuries into three categories: mild, moderate, and severe, using the emergency department severity CPT codes. We used the Delaware's healthcare claims database as the data source, also called HCCD. HCCD is Delaware's all payers database, which is managed by Delaware Health Information Network. It consists of healthcare claims, both medical and pharmacy, along with provider and eligibility information of nearly 65% of Delaware's population. Using this data, we performed the research in two phases. In phase one, we analyzed the prevalence rates of the TBI persons stratified by age group, gender, insurance type, and severity type. In phase two, we analyzed the follow-up care patterns of the persons discharged from emergency department. We looked into the proportion of patients receiving follow-up care and how many of them are receiving their follow-up care in 30 days and how far are they traveling. Let's look at some of the key findings. As you can notice, the TBI injuries were higher in 2017 with a rate of 5.92 persons per 1,000 population. If you carefully notice, the increase began from 2016. There was a change in coding system from ICD-9 to ICD-10 at the end of 2015. The ICD-10 coding is more specific and detailed. And we believe that one of the reasons for this rise beginning 2016 might be attributed to this coding transition. Now, my colleague Gurpreet will share additional findings and some recommendations. Gurpreet, take it away.
Thank you, Krishna. Let's look at some of the key findings from phase one of the study. This revealed that the age group incurring the most severe and the highest rate of traumatic brain injury in Delaware is 80 plus age group at a rate of 33.53 per thousand. Delawareans birth to 9 years of age incurred the second highest number of traumatic brain injury at a rate of 25.95 per thousand. We do see a predominance of traumatic brain injuries of various types in geriatric population, that is 80 plus, and pediatric population. The second graph, it represents the severity of injury, level 4 and 5 being the highest, and the predominance is more in older population. Let's now talk about why are older adults more predisposed. They have shrunken brain, which we call cerebral atrophy as a part of our medical terminology. There is more space in between the layers of the brain and hence more space for the blood collection, and type of the injury is also more severe because of the space being more blood is collected there. These individuals are more prone to fall and injuries. They are also on blood thinners like aspirin and clopidogrel due to cardiovascular conditions. And also, the diagnosis is challenging since they have associated cognitive diseases like hyponatremia, that is low sodium, and dementia, which makes it difficult to reach a diagnosis without any intervention or without any laboratory and scanning reports on these individuals. Let's look at other findings of the phase 2 study. We need to emphasize the importance of brain injury coding during the diagnosis and follow-up treatment because between 2016 and 2020, 34,870 Delawareans incurred traumatic brain injury, and 50% of those were discharged from emergency department with the diagnosis of unspecified head injury. And this was consistent for all the age groups. Let's look at few of the maps which we prepared while doing our research work on this project. If we look at the three maps, the first one is Delaware map, the second is where the members are residing, and the third one is provider zip code. We see that more survivors in Sussex County had to travel to Newcastle County to receive cognitive evaluations, and darker area here refers to more people visiting the provider. Again, we were curious to know Do we need more providers who do cognitive evaluation in Sussex County? Are the providers available, but the survivors and their families do not know where to find them? Or are the medical providers not requesting cognitive evaluation after someone incurs a brain injury? So these were the questions which came to our mind and maybe the future opportunities for the project to try and understand the reasons for the distance traveled by the people to receive cognitive evaluations. Let's also look at some other opportunities. Education, for example, unspecified injuries is most commonly prescribed code, and we thought the diagnosis once made can be clarified and should be converted from unspecified to a specific injury which has incurred. Also, the collaboration among the investigators, centers, countries, and discipline is essential to the advancing care for the traumatic brain injury, which means we all speak the same language. We also suggest utilizing census tract information to determine disparities in income, insurance type, housing, transportation, education, and characteristics of race and ethnicity. There are few recommendations which we have for older population. For example, being aware of the side effect of medications. Some medications they have obvious side effects, for example, blood thinners which can increase the bruising and bleeding, psychotropic drugs which can make the diagnosis difficult. We also suggest older adults to work on their balance and movement. As we age, many of us become sedentary, but it is really important for older adults to stay active and work on the balance in order to remain strong and thus be safe whenever they are alone. It's essential to create safe surfaces for these individuals. For example, not putting so many rugs, in fact, getting rid of the rugs and using slip proof backing for them. We suggest wearing appropriate footwear, especially for the individuals who suffer from neuropathy. We also have suggestion to lighten up the high walkways. Make sure stairs are well lit and consider using lamps or night lights to increase the safety for those who get up in the night. These are the recommendations we have for older population, and we are now open to take any questions.
Hi, welcome back to the stage. So I have a question for you to start with. Your data went through 2020. Did you notice any implications of COVID in your study?
So our study was until 2020, so our data wasn't majorly impacted by that. So definitely we saw a decrease in the overall TBI injuries in 2020, because as you can see from the graph earlier presented by Gurpreet, we can see in 2016, 2017 was at its peak with the TBI injuries.
Okay, I am actually, yeah, if you guys have any questions for our presenters, anyone? We have a couple of minutes before we start the next presentation. Here we go. Okay, we have a question from the audience. What are your objectives for phase 3 of the study?
So for the phase 3, our objectives are look into the social determinants of health at the census tract level to identify the disparities in follow-up care. Primarily, we are interested in, as Gurpreet shared earlier, we are interested in race and ethnicity, transportation, a number of houses owned by an individual, and insurance, and few other elements. So we already know some of the answers to these questions at the national level, but we just wanted to confirm if this is true in Delaware as well.
Okay, that sounds really great. Are there any additional data sources that you believe could provide valuable insight?
Sure. So currently, for the phase 3, we are planning to leverage our claims data as well as the American Community Survey census data. And in future, we would like to use the clinical data as well. So as I represent DIN, we are a health information exchange in the state of Delaware. So we nearly have 100% of Delaware's clinical data. But which is not allowed to use for research purposes at this point because of a legislative hurdle we had previously. But now that it's cleared, we are in the process of making agreements with the hospitals to start using their data for research purposes. So in the near future, we are actually in the process of combining the clinical data and the claims data for the hospitals, those who have already provided their agreement. So we'll soon start be using the clinical data.
Thank you, Matt. That was a great question. Our next question is from Don Garland. Do you think there is a need for increased public awareness campaigns or educational programs to promote brain injury prevention?
That's a good question. So it's always good to have the increased educational campaigns or educational programs, but it's also important to consider the effectiveness of those programs, how well they are developed, the effectiveness of their design. So it's important to consider various stakeholders like the community leaders, the TBI survivors themselves, their caregivers, and it's important to consider their opinions into consideration and develop the awareness campaigns accordingly so that they're much more effective.
Okay, well, thank you both for your great presentation and for your time. If you have additional questions for Krishna or Gurpreet, please put them in the chat and we'll get back to them at the end of the presentations. So for now, we're going to move on to our second presentation, which is our next presenters are Claire Leather and Sharon Eulery. Claire is the program manager for public reporting, responsible for working across teams and with external stakeholders to develop projects, track activities, and ensure accurate and timely releases of public reports. She focuses on legislatively mandated reporting, state contract reporting, and ad hoc requests from legislators and other key partners. Before joining Civic, Claire spent over 6 years at Children's Hospital Colorado Foundation, focusing on stakeholder engagement and project management on the donor relations team. She holds a Bachelor of Arts in Political Science from the University of Northern Colorado and a Master of Public Health from the Colorado School of Public Health. Sharon is a research analyst who works with public agency staff to report high-level, policy-relevant metrics and trends in healthcare, insurance claims, and code sets. She is HSRI's technical lead for the Colorado APCD, using SQL to prepare large data sets and analyze data. She led the development of comprehensive data sets on per procedure in-network costs, including anesthesia, to support surprise billing legislation for both Maine and Colorado. Claire and Sharon, welcome to the stage.
Hello, everyone. My name is Claire Leather. I am the Public Reporting Program Manager at the Center for Improving Value in Healthcare, and I'm joined today by Sharon Eulery, Research Analyst at HSRI, our data vendor, and our partner in creating the provider payment tool, which is what we're going to talk about today. Before we get into the tool, I want to just briefly touch on the data source, which is the Colorado All Payers Claims Database. This database contains over 1 billion claims going back all the way to 2013, with over 70% of the covered lives in the state of Colorado for medical claims, which includes 40 commercial payers, Medicaid, and Medicare, so a very robust APCD. So excited to talk to you all today about the provider payment tool. Some background about the tool. The impetus of this report was a piece of legislation, Senate Bill 22068. The bill requested that Civic, as the administrator of the Colorado APCD, provide price information for Colorado providers based on CPT and HCPCS codes for medical, surgical, and diagnostic services. This is a unique, one-of-a-kind tool given the amount of data that is displayed, which we will get into shortly. So let's dive deeper into what is included in the tool. The legislation outlines a couple of key things for the tool to show. One is codes and years. So the tool has all current codes with sufficient volume, so that looks like 30 or more claims statewide for us, from 2018 all the way to 2021. We also show the codes via payer type, so breakouts for commercial, Medicare, Medicaid, Medicare fee-for-service. And we also display the payments as a total allowed amounts. So total allowed amounts is the payer and patient liability combined at the 20th, 50th, 60th, and 75th percentile. And we also include averages. And last but not least, we have a special section for anesthesiology calculations because anesthesiology payments are reimbursed very differently from the other kinds of providers. And we can get into that when we show you the tool.
So let's do a brief demo of the tool. So we go to our website, civic.org, go to Get Data, Public Data, Focus Area, and all the way down to the provider payment tool. So this is what the web page looks like. We have a little overview of some of the information I shared with you earlier. Scrolling down a bit more, we have some key considerations about some of the limitations of the report. And as you scroll down, you get the tool itself. So I'm going to walk you through some of the basics of the tool. The first thing you can do is select the year you're interested in. From there, you can select the payer type. From there, we look at place of service. So it can be inpatient, hospital setting, or outpatient. And then here's the geography type. So we have 3 different geography types to sort of capture the diversity of the regions in Colorado. We have it at the county level, at the Division of Insurance level, which is sort of the regulatory level, and then we have the statewide level. So I'm going to select county. It's going to turn blank, but don't be worried. Here you can select the actual county from geography. And then this is a list of provider type or setting. Sharon will go a little bit into this, the categorization of this, but you have a lot of different places, a lot of different categories to choose from here. So I'm going to stick to specialists and osteopathic providers. And here you can see all the CPT codes that pop up. Now, if you have a specific CPT code that you know, you can type it in here and that CPT code will populate, which is very nice. And then you have instructions. Just in case you forget all of this, there's an instruction to guide you through the report. Second tab is the anesthesia piece. So this is the most complicated part of the report of the tool. It's because anesthesia is reimbursed a little differently. So there's this fancy calculation that has to happen. So this tab does the calculation for you. So again, you have the same filters that I just went over, but this orange ribbon has a couple of new items for you to select. So choosing the code, the anesthesia code description here. Selecting that, the physical status. So physical status is the physical status of the patient. So here's a little cheat sheet that folks can use. So you select that. Then the price modifier. So the price modifier for anesthesia is who is performing the anesthesia procedure. So you select that. And then how long is the patient under? So this is where you select the time units. Every unit is 15 minutes. So if you wanted an hour, you would put in 4, and then it would come up with a reimbursement rate for you. The conversion factor comes from the Colorado APCD based on the percentiles that we've talked about, but the reimbursement rate is calculated uniquely every time you put in these inputs. So pretty complicated. Sharon will go into a little bit more about the methodology in a second.
So how can this tool be used? There's a myriad of ways. First, for employers, self-insured employers can understand how their payments are versus statewide county and DOI payments. For the fully insured employers, they can look at pointing their employees to the tool if there are questions on bills or understanding what a reasonable cost for a procedure is upfront. For payers and providers, it can benchmark how their payments compare to their peers. For policymakers, it can identify variations in payments for procedures across the state. So as I mentioned before, Colorado is geographically diverse. We have urban and rural communities, and sometimes based on where you live, you might pay a different price for a procedure. And then lastly, for consumers, they can use this tool to understand what common or reasonable prices for a provider bill in their community would be. Now, I'm done with my portion. I'm going to pass the baton off to Sharon so she can talk a bit more about the methodology behind the report.
Thank you so much for that summary, Claire. So to sort of sum up what Claire has been saying from a methodological standpoint, this tool looks at fee-for-service payments. It looks at allowed amounts. It looks at professional claims only, and it looks at in-network claims only. There's a small side note there that Medicare fee-for-service doesn't submit data in a way where we can distinguish in-network and out-of-network claims, but Medicare fee-for-service so rarely pays out-of-network claims that we felt confident just including all of those as in-network in our data set. The biggest methodological challenge was just the volume of codes. Thousands of codes with then a bunch of different breakdowns. And sort of the flip side of that is that there are a lot of procedures that are rare enough that we didn't have good data to present. So we decided on a threshold of 30 or more claims statewide and said you have to have at least 30 claims within one set of parameters to publish that data. And that allows us to have a sense of reliability in the data, that if you see differences from year to year or location to location, that is most likely due to underlying trends and not to anomalies in the data. We did limit 2 codes that were in effect in 2021, excluding deprecated codes. And we had to make a decision about how to determine costs based on a per unit cost or the total for a procedure. So we went to the data for that. We looked and said, if 3% or more of the claims have more than 1 unit submitted, then we'll assume that this is reimbursed per unit. And if it's less than that, we'll figure those might be data errors and calculate it on a per code basis. Another methodological challenge we had is that the legislation asked us to show costs based on provider type. Unfortunately, the way that claims are billed, the provider information is often for the organization that a provider is part of rather than for the individual. So sometimes instead of saying this claim was billed by a behavioral health specialist, it said this claim was billed at a community health clinic. So we ended up on the tool with a combined category for provider type and setting based on whatever was on the bill. We did opt for the most general categories that were still useful to users in order to avoid suppressing any claims that we didn't have to due to carving it up into smaller volumes. There were 2 specific categories of codes that were particularly challenging due to data issues. Medical transportation claims are a hot topic in surprise billing, and part of that is because the clear majority of ambulance claims, at least in Colorado, are out of network. Since this tool is about in-network costs, that means that most ambulance claims are outside the parameters for this tool, and so we end up with these reported costs based on a pretty small percentage of what's actually going on in the universe of medical transit. So we did include those procedure codes, but they should definitely be interpreted with that context and with a degree of caution. Another sort of specific area is anesthesia, which is also a hot topic with surprise billing. And the reason this is challenging, there's some of that same issue of a lot of anesthesia is billed out of network. And the other piece is that billing is, and reimbursement is calculated very differently for anesthesia compared to a lot of other procedure types. But sort of on the plus side, the way it's calculated, we were able to put all anesthesia codes together to get a large enough group of information. And then we used the standard reimbursement formula. We sort of reverse engineered it into estimating a reimbursement rate for anesthesia in general, and put on the website a formula that allows you to look at what that would mean for different types of anesthesia under different conditions. Another challenge with the anesthesia data is that units are not always properly submitted. And so we did a fair bit of cleaning, trying to understand what was meant, and where we just didn't have units at all, we sometimes had to throw that out, but often we did some sort of statistical wizardry to fill in best guesses. And I think that wraps it up for us. Thank you very much.
Thank you. While we're waiting for questions from the participant or from the audience, I have a question. I'm going to use moderator privilege here, and I have a question for Sharon. And I would like to talk more about the provider and setting combinations that you use. When you say setting, do you mean inpatient and outpatient, or are you looking for something more specific?
Thank you. That's a great question. So the legislation is trying to look at, they want to be able to uncover differences in the prices for example, a specialist versus a general practitioner doing the same procedure. The challenge is that that kind of information can be submitted on claims in a variety of different ways or not at all. And because of volume issues, we didn't want to end up with contradictory information or dividing everything up into such small categories that we couldn't present the data at all. So what we ended up deciding to do is looking at the billing provider only and using whatever taxonomy the billing reporter has said that they are in NPES, which is a national public data set where providers provide their own information. It's all self-reported.
Thank you. Great example. Our next question from the audience is, what is conversion factor here?
also a good question. The way that anesthesia billing is reimbursed is by using a conversion factor that's the price that was set, that was agreed upon in a contract, and then also other elements like the length of time that modify what the final cost is. So the conversion factor is the agreed upon contracted amount.
Are there other questions from the audience? If not, I have one more at least. Okay, so can you speak a little more as to what prompted Maryland to create a program that allowed participants to design their own episodes of care? I'm sorry, I jumped a whole question. Sorry. How did you navigate creating a public price transparency tool that would garner attention and strong opinions from the many different healthcare actors, providers, insurers, hospitals in Colorado? I apologize. I had a question for the next one and I skipped down. My fault.
No worries. I was like, Maryland, we're in Colorado. So I'll take this one. I'll take the less difficult questions, Sharon. So this was a public report. This was a legislatively mandated report. So that helped us when starting these conversations, but we were really proactive with those actors in our community. So we reached out to the Association of Colorado Healthcare Plans to sort of show them what we were doing and why we were doing it and getting their feedback. And then we also worked with our anesthesiologists to better understand what was happening with the billing because it is so complicated. So we ran through our methodology with them to make sure that we weren't missing anything, any of the nuances in anesthesiology billing, and making sure that the actual interface was user-friendly and could actually be useful to the anesthesiologist and those who are working with billing. And then, of course, we worked with our state folks to help us make sure that we were meeting all the requirements in the legislation.
Okay, another question from the audience from Margaret. Do you have any idea of how or if the tool has been used by different entities or people?
Yeah, so I think the first or second week we published, we got an email from a behavioral health specialist working in a rural community who asked specifically about some nuances in the data, and they were using the tool and found it really helpful. So that's kind of who's been using the tool, and that's one example. We also have researchers in our state who have used the tool to sort of gauge what's happening for specific CPT codes. So there is a lot of information in it, and it is geared towards providers, but it does have multiple use cases.
Okay, if you guys have additional questions for either Claire or Sharon, please keep putting them in the chat. And when we bring them back out at the end of the session, we'll address those for you. So moving on to our third and final presentation, our presenters for this presentation are Nathan Hedberg and Willem Daniel. Nathan, for the past 15 years, has been engaged in healthcare policy consulting and research, working with a wide range of startups, provider groups, and stakeholders in the industry to better leverage data systems to understand and improve U.S. healthcare system. His primary area of focus for the last decade has been in working with episodes of care and CMMI innovation models, including CJR, BPCI Advanced, and the Maryland Care Redesign Program. Nate earned his Master of Public Health from the University of Michigan and his undergraduate degree in molecular neurobiology at the University of California, Berkeley. William Daniel was the Deputy Director for the Health Services Cost Review Commission, the organization responsible for managing all payer total cost of care in the state of Maryland. He was responsible for creating value-based payment programs for providers, including bundled payments, patient-centered medical homes, and more. Prior to that, he worked at the Centers for Medicare and Medicaid Innovation on several alternative payment models. He has since left government service and now runs care delivery strategy for a commercial payer. And as I'm sure you heard just a minute ago, I already have a question for you. So after your presentation, I'll restate it for you. Welcome to the stage.
Okay, I'm going to be talking about CTIs or care transformation initiatives. What these are is a value-based payment program designed by the state of Maryland in partnership with our providers, so typically hospitals, but also physicians and some other partners. What the CTI does is it allows the hospital or the other participants to capture the total cost of care savings that they create through better care management. So this is very similar to a PCMH or a bundled payment program. The real difference between our CTI programs and some of the other programs that exist nationally is that we allow providers to have the full control over the attribution rule to assign a patient to them. And the reason why we did this is that as we worked with our providers in the state of Maryland, we realized that value-based payment programs that are developed by CMS or by payers, typically do not perfectly map to the patients that providers are targeting on a clinical basis for better care management. And that means that when we have, programs that are created by the payers themselves instead of by the providers, there's a mismatch between the financial incentives and the rewards for the providers. So what we in the state of Maryland do with our CTI program is allow providers to define their own attribution rules, to essentially pick the patients who are under active care management, and then we pay the providers the savings from better care management on those patients. Now, when we started this program, developing a CTI would take a couple months because developing a value-based payment program is a complicated endeavor. However, working with our partners at HMetrics and my colleague or former colleague, Nate Hedberg here, we managed to improve that, or they managed to improve the time that it would take to develop one of these value-based payment programs down from months to literally just with a click of a button, a provider could see which patients were attributed to them. And we think that that data process allows providers to have a much greater control over who's attributed to them. And that confidence will lead to more success in value-based payment programs because they can have a higher degree of confidence that the people they're investing care management resources on are the ones that they're being measured on for the value-based payment programs. Next slide, please. So how the CTI program works is each May, we allow participants to create new CTIs or modify existing CTI attribution rules. We also allow those providers to determine how long the patient is going to be attributed to them, whether this is going to be a 90-day episode or a 365-day annual performance year. And then every month, we report out how those providers are doing in their value-based payment programs. And this, I think, is also a really important part of the value-based payment programs. I don't know how many of you have experience with CMS and BPCIA or the ACO programs, but there can sometimes be a significant delay between the performance period and when you get data. In our programs, thanks to Nate and HMetrics effort, that data is pushed out to providers monthly, which is about as close to real time as we can get with a claim system. Over to you, Nate.
Sure. So the entire time when we were approaching the first enrollment period, as Will mentioned, we were really thinking about scalability. We knew that we've got 47, 48 hospitals in Maryland. All of those hospitals would have multiple users who are designated as users who can come in and submit CTIs on behalf of their institution. So all of these dozens of users coming in, creating, editing CTIs, and a relatively lean staff at the state supporting the program meant we had to be able to manage this really efficiently. So what we ended up doing was creating this online portal that users could access via the state and regional HIE CRISP. They have a single login to access all of those resources. Those users could come in and designate of the different thematic areas which CTIs they wanted to submit. And participants were allowed to submit as many CTIs as they wanted. And you can see at the right here, the start of that workflow where they would come in, select which criteria they wanted to customize. All of the different thematic areas had sensible default values that we would apply in the absence of any other overriding criteria. And then the state staff could come in and review and evaluate those CTIs using the same interface before approving them. So checking for things like making sure there was a sufficient volume in the CTI to establish a target price, ensuring that participants weren't trying to claim the same providers on their panels, things like that. And the fact that all of this information was stored in a standardized, structured fashion meant that we could also very easily generate human-readable CTI definition summaries. We'll talk about it in a moment, but all of this data is very transparent. Everything is visible to all participants in the state. And so if I saw another hospital's CTI and I was interested in it, I could actually look at their definitions and potentially reach out to them and talk to them about what they were doing if I wanted to model my CTI after theirs. So Will talked about the flexibility that we gave to the different participants. And again, this was really based on the data that we felt was continuously available and robust enough in the claims data that we received from CMS to be able to consistently define those cohorts. So we would start with global parameters. Which baseline period did the user want to select? We allowed hospitals to go back as far as 2016, depending on when they'd established and started working on their intervention, setting episode length, and inclusion and exclusion trigger criteria. But then they could also select from beneficiary characteristics like chronic condition type or number of chronic conditions. They could define their CTIs based on service characteristics during the period, like prior utilization or ICD-10 coding. And additionally, in limited circumstances, they could also select provider characteristics like patients attributed to a specific physician that they were collaborating with. As I mentioned, transparency was a big part of this program. So like Will mentioned, we processed the claims data as it came in every month, aggregated that, and made available non-PHI reports in this portal so that every single participant could come in and see at the state level all of the CTIs. On the left-hand side here, you can see the state summary that gives us the CTI names, the total number of episodes initiated, as well as the total payments associated with those, and an estimate of what the current savings and statewide impact of that CTI was. Additionally, you could click through it on the right-hand side. Each CTI had a more detailed, but still aggregate non-PHI profile that would compare things like payments over time and beneficiary characteristics between the baseline and performance period to give a bit more insight into how that CTI was performing. And again, the emphasis here was that the data is visible to everyone. If folks see that a particular participant is doing well at managing transitions to skilled nursing care or palliative care, that information is available and can hopefully facilitate additional discourse. Like Will mentioned, we did have to scale this up a lot, so we're very dependent on parallel processing. The underlying engine utilizes something called PySpark. It's a combination of Python and Apache Spark, and that allows us to very quickly run all 300 CTI definitions across that entire statewide Medicare claims data set on a monthly basis and still meet our usual production schedules. With that, Will, I'll hand it back to you. We can talk about initial results, and then I think we'll be ready for questions and discussion.
Great, thanks, Nate. So I think that many states and many payers at the start of their value-based payment journey think of it as a very daunting project. I think from our perspective, what we realized is in the state of Maryland, the daunting part was not actually getting the value-based payment designed. We have a lot of expertise in the state, Johns Hopkins, University of Maryland, et cetera. And that really the daunting aspect was getting the data into the hands of those participants so that they could make informed decisions. And once we were able to do that with Nate and his colleagues' very good work, we got pretty significant results. We saw about a little bit less than 3.5% savings in the first year of performance. And we expect that to grow as these programs mature. So we were very encouraged by that. And as you can see, the number of CTIs is currently doubled or slightly more than doubled. So we would expect, hopefully, those savings to continue to grow. We were told to keep this to 10 minutes, and I think we may have just run a little bit over. So happy to take questions.
Okay, so I'd like to again start with the one I accidentally asked earlier. So it seems like a really innovative idea to allow participants to design their own episodes of care. What prompted Maryland to create it?
So I think the number one prompt was a recognition that when payers design things, they design things according to their own payment rules and not according to how clinicians are actually focused on patients. So I think a really clear example of this is if you look at CMMI's bundled payment programs, they target those programs based on DRG triggers. And when we asked our participants to design their bundled payment programs, they targeted based on people with chronic conditions. So not a hospitalization episode, somebody with COPD, somebody who kept coming back to the hospital, et cetera. And so we wanted to tailor the value-based payment more closely to actual clinical efforts on the ground.
Were there policy challenges that came with that?
What was the question?
Were there policy challenges that came with that?
So the policy challenges, I think, were principally an organization. If you go to an entire state and you say, everybody design your own value-based payment program, you get like 500 ideas. And Nate and his team is very good, but 500 ideas would overwhelm anyone. So we did go through a process of refinement and sort of grouping what we call thematic areas. And we realized that, the majority of people weren't doing things that were that different from one another. Maybe slight variations, but everybody had a palliative care management program. Everybody had a care transitions program for targeting some chronic condition. And so by going through and organizing, we got to the point where the variations were sort of manageable data questions. Some people were focused on frequent utilizers with 3 or more hospitalizations in 180 days. Some people focused on 2 or more hospitalizations in 90 days, right? That's a relatively small distinction and one that Nate's team was able to accommodate pretty easily.
Okay, a question from the audience. Have you had any considerations or equity concerns around residents who are not under any of BBC initiatives due to the provider-based attribution methodology?
Yeah. Really excellent question. So when we looked at this, realized that there were differences based on what type of value-based care program people were in, but that our programs, different types of programs got to every population, right? So if you look at people in our programs, they look pretty demographically and economically similar to the state population generally. But if you look at specific types of programs, there are disparities based on race and demographic income. So what I mean by that is, our primary care programs were concentrated in areas with very high penetration of primary care providers, and those tend to be wealthier and whiter areas of the state. And our ED management programs tend to be getting, sort of anybody who comes through the ED. So we do have, we are reviewing aspects of the delivery system that we need to focus on. I think those are less in terms of what gets captured in a value-based payment program, as it is, if you have a primary care program and you have access gaps for primary care, you're going to have access gaps to primary care PCMH programs.
Okay, and then one from Cameron. You said PySpark allowed your regular updates of all the CTIs to be fast. How fast are we talking?
So the CTI updates are based on the CCLF file that Maryland receives. That covers a rolling 36-month period. Typically, we get about 420 million claims during that 36 months. So that's kind of our working claim population that we start with. And like we mentioned, we've got about 244 CTI definitions active for this year. Once the CTIs are designed, current processing time is about 2.5 hours to generate all the results. And then we spend usually a week doing additional quality control and checks on top of that. But the actual processing of it is really lean at this point.
Do we have any other questions from the audience?
I might add also, and well, I'm not sure if you've been tracking, but for folks interested in the equity question, the state's actually right now working on a couple of evaluations addressing those questions specifically. It'll be a while before they come out, but if you track the work that the HSCRC is doing, I believe they're planning on making those reports available in 2024, because it's, again, something that has definitely caught a lot of interest. So worth following there, because we'll continue to kind of monitor that and look into it as time moves forward.
Okay, well, thank you for an amazing presentation. And I think it's time to welcome all the presenters back on stage. Welcome, everyone. Are there questions from the audience for the panel? So I think this one is probably for Krishna. It's from Cameron. What do you think are the causes for the large spike in the pediatric group?
Sure. Gurpreet, you want to take that one?
Yes, please, I can take this one. There are physiological factors that are associated with the pediatric age group, which for the reason for them to being more prone to the injuries, such as they have thinner cranial bones, they have lack of musculature to absorb the transmitted forces, their brain is in developing system, the neurons are just developing, and there's an increased susceptibility to the chemical and the metabolic changes which occurs to the brain. So all these factors, these are physiological factors which make them more prone and susceptible to injuries as compared to the elderly or the adult population.
And I just want to add to what Gurpreet just said. So this is related to the babies. So I know babies are, we all know they are adorable, and some playful dads, they like to throw their babies in the air and catch. So this catching game will put them at the risk of shaken infant syndrome. So we just need to bring awareness on doing so can create some traumatic brain injuries to the babies. So that's one important thing. And also to add, we also need to secure our furniture to the wall just to avoid tipping. So yeah, those are my two other recommendations.
Okay, so just a question for the panel. Well, we can each take turns answering, but just from your own experiences and all of the work that you've done, how can you help your healthcare organizations measure and communicate the value from the analytics to your stakeholders? Willem, would you like to start? You're first on my list.
Sorry, I got a little bit of feedback. Would you mind repeating that?
Sure. How can you guys, after doing all of this great value-based analytic work, help the organizations that you work for communicate the value of your work to their stakeholders?
Yeah, it's an excellent question and one that we haven't been very good at. If you have a conversation with the average person on the street, they're going to say the insurance and healthcare system is way too complicated. And if you tell them, well, I designed this value-based payment system and made it a little bit more complicated, but in a way that does something good for you, you're not going to get a lot of traction there. And I think one of the things we have to realize is that, convincing somebody about the value of a delivery system reform is really hard. And I'm not sure that payment redesign is the place to start, right? People care about things that they can see. And so, one of the things that I like to focus on when we talk about our value-based payment programs is, we created a program where we give doctors money so that they see you after their office, after 9 to 5, after their normal office hours, so that you can go to your doctor on the way home from work instead of taking off time from work. And so I think, here we have to really focus on outcomes and not sort of the payment redesign stuff. The payment redesign stuff is the thing that, you tell to a politician or to an actuary or a finance person somewhere so that they let you do the stuff that, you can really take to beneficiaries and convince them that there's real delivery system going on, a reform going on that they benefit from.
Claire, would you like to answer that question as well, since you have this really amazing tool that you've built?
Yeah. So for us, at Civic, we're really a neutral entity, and we're not trying to convince folks one way or the other. But we are trying to provide a lot of public data that we think we call them our change agents, could find useful and sort of actionable data that they could take and make policy recommendations, change things in their organizations to increase price transparency, increase value-based payments. So we have all kinds of public data that we release in order to provide stakeholders across the spectrum, across the state, with the information that they need so they can make these decisions that hopefully will better the health of Coloradans all over.
And Krishna, you guys had some, and Gurpreet, you guys had some recommendations for your stakeholders on how to improve elder care or elder safety. How would you guys address this question?
So we have taken these recommendations to the State Council for Persons with Disabilities, and together with the State Council, we presented these findings and recommendations at the Brain Injury Committee, which comprises of the TBI injury survivors, their caregivers, along with the Brain Injury Council. And we have presented at various conferences along with the State Council, and also we have been assisting them with a research paper where they could publish them in the state journal so that the findings or the recommendations are disseminated to the general audience as well.
Great. Nathan, would you like to weigh in here?
Yeah, I think to build off of what Will said, it is important to target your message to the audience and make sure that I think, especially with a conference like this, like we all get excited about technology and about data. And I know if I'm not watching myself, I'll tend to start talking about that. A lot of the folks that I work with, that we work with day to day, they're busy folks either working in hospitals, if they're a hospital administrator, a program manager, or, they have other kind of higher level concerns if they're a stakeholder advocate. And so really just taking the time to think, okay, if I'm in this person's shoes, what do I really care about? If I'm running a CTI, I just want to know, am I reducing readmissions? And if not, like, what's causing that? How do I get that information to them so that they can see, oh, here's why this system is valuable, why the state is spending money on it. Even if, the things that we get excited about is how much compute time it takes to run millions of claims. And again, it's just something, at least for me, I have to keep in the back of my head when I'm interacting with folks, and just keep that kind of perspective in mind.
I fall into that category as well. Sharon, would you like to round out the panel conversation on this one?
Sure. I think for the provider tool in particular, I think it depends which stakeholders we're talking about. For our tool in particular, it was requested by the legislature, which requested it because providers were asking for that data. So those stakeholders, there's no need to convince them of anything. I do think it's a useful perspective to keep in mind how we can make tools that are designed for one stakeholder also useful to others. And we tried to do that by making it as user-friendly as possible so that just users can use it. But I think there wasn't a lot of convincing that had to happen in this particular case.
Gotcha. Thank you all for these great and insightful presentations. And as Norm has put on the screen, we have the closing plenary in just a few minutes. So it was great speaking to you all, and I really enjoyed this. Thank you very much.
Yeah, thank you, Angela. Thank you, all of our presenters. We're excited to continue this concept and this topic here in just a few minutes. So we'll see you all over there at the next session. Bye-bye.
Thank you.